So we're here at the International Conference on AIDS. This is our last interview. We're here with Anton Pozniak from the Chelsea Westminster Hospital in England. And we appreciate you taking this brief moment because you have to catch your flight.
Yeah, I
so
do.
we'll make this really quick. I think it's the essence of what you were focusing on has been treatment as prevention. So take us to the important pieces that are what we want to get out to the public.
Yeah, well, I think that one of the major issues for treatment as prevention is going to be the implementation. A lot of this conference was about implementation of TASP, because the cascade of care, when we look at it, the best countries in the world are Switzerland, Australia, and the UK, and they've got fantastic healthcare systems. And the thing about the cascade to achieve this 90-90-90 that UNAIDS are going forward with is to ensure that the healthcare systems are robust enough, strengthened enough, and integrated enough, and they've got to be quality. The healthcare systems. Now, how do you do that without having to spend as much money as people do in the UK, Switzerland, Australia? And that means, as far as I'm concerned, not having to have doctors do all this, not having to have patients come every month. And there's some great work on community clubs that they use in South Africa. Where people can actually have their drugs delivered to the clubs and pick them up. They can have a buddy who can collect their drugs in case they're sick, their child's sick, or they've got to go and do something else. That they're mainly looked after by nurses or even healthcare assistants, and then they get only referred up to doctors if there's a problem.
Right. Maybe even AIDS service organizations might be able to do this as well.
Yeah.
And as long as in conjunction with, because they're already doing that with testing.
Yeah.
So that might be another way to implement.
And some of the problems that we have is testing the right people. I mean, Russia tests, I think it was over 12.5 million people in one of the years, 2013 or 12, but they tested all low risk people. So really, if you want to find the undiagnosed, you've got to make sure you're testing the high risk. The problem in Africa is that if you go to places where there's high antiretroviral distribution and high rates of testing, if you then go and test populations, you find up to 40% of patients positive, and that's one of the studies they did from South Africa. It was phenomenal.
It is.
So really people have got to get the testing right. The other thing, of course, is PrEP and prevention. And I think that all the data shows that if you take it four doses a week, or intermittently like an IPA, and you're at risk of HIV, whether you're male, female, transgender, whatever, then you really should get access to PrEP. Right. Because we all know that in disease prevention is better than anything else.
Well, and it's also the cost-effective route.
And we need extremely cheap. At the moment, Truvada, or if the TAF drug comes and looks better, then that could be a combination. But we need that to be extremely cheap and extremely accessible for people who are at high risk.
So if they take it right, it'll work right.
If they take 4 doses a week, it looks like that it'll work.
Enough,
And if they don't want to take that much, then what you can do is take 2, like Ipagay showed, 2 pills a couple of hours before you have sex, and then 1 at 24 hours later and 1 at 24 hours later. So if it's just a few times a month, then
seasons of risk, or however seasons of love, however they classify it.
Yeah.
So do you think this is something that rolling out? I think we're talking about worldwide. This is something that is maybe going to be addressed by the World Health Organization, certainly, and also by Clinton Foundation, maybe Bill Gates Foundation, because these are all big players that might be able to intervene and realize this is, at least maybe use some way to leverage some of the best pricing and so forth for this.
Yeah, well, I think with people like WHO set standards and guidelines and organized countries, but in terms of implementation, it's got to be, we've got to have resource. So there's got to be people, which is education and training, to be able to do this, and there's got to be money for it, and that's other organizations. The issue is, can countries, health services, start affording this, or will we be always dependent on donors? Actually, when you look at the global scale of it, it looks big and it looks like billions of dollars, but for every HIV diagnosis you avert, you stop, or for every person you treat and stop a transmission, and for every person that takes drugs goes back to work, you save trillions of dollars.
And eventually the herd immunity takes over, and I mean, it certainly we're nowhere near that at this point, but we could be, and if we were, it would be a massive change. In
It would be a massive change. However, I just want to end on this. If you want to end HIV, not AIDS, HIV, by drug therapy, you've got to make sure that everybody in the world who's HIV positive is on pills for all of their life. And you'd only end it when the last person died. Hopefully a happy, long life.
Right. Unless we come up with a cure in the meantime.
Unless we come up, and we hope that we will.
Right. Well, I thank you very much for
Thank you
your
very
time.
much indeed.
And you have a very good flight back.
Okay, thanks.